All right, so talking about the urinary system, it's defined by a pair of kidneys and ureters, which effectively filter the blood that comes in through the branches off the abdominal aorta, which are the renal arteries. So the renal arteries contain unfiltered blood. They enter through a network of vessels into the kidney, and then that blood leaves the kidney through the renal vein. So the filtered blood is found in the renal vein. The unfiltered blood is found in the renal artery. And only 1% of the blood that's filtered that enters into the kidney will actually become urine, which will leave the kidney through the ureters to be stored in the bladder. So the kidneys, the ureters, and the bladder are the organs of the urinary system, and the primary function is to filter blood. Again, and only 1% of the blood that's filtered by the kidney actually becomes urine. And the interesting part is we are constantly making urine. So we would be tinkling ourselves throughout the day if we didn't have a bladder to store this urine as it's being produced. So the primary function of the bladder is just to store the urine so we can release that urine as the bladder fills at a convenient time, because urine production is continuous. So the urinary bladder, its only job is to store the urine as it's being produced and transported from the kidneys to the bladder by the ureters. And you've heard the word peristalsis when we studied the digestive system. It's the same thing that brings urine from the kidneys to the bladder, are those smooth muscle contractions of the ureter, which we call peristalsis. So moving on then. Oh, and where we find the kidneys is kind of on the back wall of the peritoneal cavity. So that's why we say they are retroperitoneal, which means they're on the back wall. Retro kind of means backwards. So they're up here on the back wall, and they're surrounded by a rich casing of fat. So they don't really have good protection in the lower abdominal cavity, below the ribs, but they are protected by that fat. And people that lose a lot of weight can sometimes cause a drooping of the kidney, and the ureter will kink, and that will interfere with urine flow. So we have to be a little bit careful about that. Like I said, functions of the kidneys are filtering blood, and through hormones and solute concentration, like diffusion, we see that the capillary, the glomerulus, is very porous, and we have active transport and osmosis occurring in the cells that line the nephron, which is the structural and functional unit of the kidney, which we're going to talk a lot about. We kind of see this back and forth movement between the bloodstream, this is the blood vessels here, and the vessels of the kidney, the tubules of the kidney, and that can control the amount of water in the bloodstream, and it can control the amount of solutes in the bloodstream by this exchange that occurs in the kidney between the tubules of the kidney and the bloodstream. So kidneys are a big player. Out, excuse me. Out, come on, Piper, out. Get. Troublemakers. All right, so big players in blood pressure. So they can control the fluid amount in our blood vessels. So obviously the more fluid that remains in the bloodstream and not going into the kidneys, the higher the blood pressure. And if we have too much urination, we can drop our blood pressure because we're losing fluid. So there's hormones that control this, and we'll talk more about that. We know that the kidneys secrete a hormone called erythropoietin. We talked about that in the cardiovascular system, called EPO, and that stimulates red blood cell production when oxygen levels are low. And that's the job of the kidneys, to secrete that hormone, erythropoietin. And the kidneys also play a role in synthesizing vitamin D. So we have some vitamin D synthesis that occurs in the skin with the help of UV light, but it's not completely converted to its final form until it enters the kidney. So the kidney does that final synthesis of vitamin D, and then that helps us absorb calcium from our digestive tract. So, and vitamin D has lots and lots of other functions as well. It plays a big role in mental health. They find that people with low vitamin D levels often have symptoms of depression. So they sometimes check for vitamin D levels in people with chronic depression.
And we know that that has a role in seasonal affective disorder. People that are, depressed in the winter months when there's less exposure to sunlight, it might be because there's less vitamin D production as well. So moving on then, the structural and functional unit of the kidney is the nephron. Make sure you highlight and underline that term and this definition because that'll definitely be on the test. So the nephron is just a connection of different tubules within the kidney that has different functions. So the parts of the nephron start with Bowman's capsule, that's the structure here, that receives the first part of the filtered plasma that's squeezed out of the bloodstream. And then that enters the first part of the nephron called the proximal convoluted tubule. Convoluted just means kind of changing direction, this kind of back and forth, zigzag appearance of this part of the tubule is where it gets its name, convoluted. And proximal just means it's real close to the start of the filtering process. So proximal, close proximity. So this is the proximal convoluted tubule. And then it dips down deeper into the kidney tissue, down here into the medulla, which if you watch the lab video, you'll learn about all those parts, but it dips down deep into the medulla. This is called the loop of Henle. It looks like a hairpin loop. So we have the descending limb of the loop of Henle and we have the ascending limb of the loop of Henle, and they have slightly different functions. And then we get to the end here, and this is called the distal convoluted tubule. Distal meaning distant. It's further away from Bowman's capsule where this whole filtration process started. So this is the distal convoluted tubule, and that completes the nephron. So the Bowman's capsule, the two convoluted tubules, and the loop of Henle makes up the nephron. And these nephrons connect to a common vessel, common tubule, called the collecting duct. And you can see there's different connecting points here for different nephrons. So this is not part of the nephron, but it's an important structure within the kidney. It's kind of like the drainage pipe for all the different nephrons that are doing this filtering process. So we can see by looking at this, the different functions of the different parts, we can see most of the fluid that enters Bowman capsule and enters into the proximal convoluted tubule, it's reabsorbed. And what that means to be reabsorbed means that it was first absorbed into the blood in the digestive tract. When you bring fluids and electrolytes in through your diet, your glucose, amino acids, those are digested and broken down and enter the blood. They leave, so they're absorbed first in the digestive tract, then they're filtered out into Bowman's capsule, and then there's blood vessels wrapped around these tubules that reabsorbs that back to the blood. So most of the water that we filter out goes back to the blood. We don't want to pee away all the water that we just drank and absorbed from our digestive tract. And sodium and bicarbonate ion, glucose, amino acids, those are essential nutrients. We don't want to pee that away. So we reabsorb that back to the blood by special processes, active transport, it right away in this proximal convoluted tubule. And then the rest of this process down the loop of Henle, this is kind of highly controlled depending on the needs of the body, if we're, low on water or have too much water. And then we see in the last part of the nephron, this distal convoluted tubule, this is where we see secretion, which means we're going to take things out of the blood and put them into the tubule, kind of here at the end of the piping network. So things like potassium are secreted into the distal convoluted tubule. And when we break down different medications like antibiotics, those are secreted into the distal convoluted tubule to get rid of those byproducts of those medications. And you may have noticed if you've ever been on antibiotics, it kind of gives a strong odor to the urine because of those byproducts from the antibiotics.
So in the very first part, the first convoluted tubule, that's where 70% of the water disappears?
65%, yeah. Most of the water goes back to the blood here.
Okay.
All of the glucose goes back to the blood, and all of the amino acids go back to the blood. Our body never wants to get rid of glucose. And if we can figure out a way to prevent that reabsorption and storage of glucose, we would be, the next best thing to sliced bread, because that's the number one reason for weight gain and obesity, right? Is storing of glucose that we don't need and that we're not, using through our movement and activity. So we store glucose. The body is very selfish when it comes to glucose. It's always preparing for famine. And anytime we have glucose or amino acids, which are essential nutrients, entering into the kidney, that proximal convoluted tubule is going to steal them right back and put them back in the blood. And if we don't need it, it's going to be stored as fat. So that's, kind of a critical thing. So if we ever find sugar in the urine, if glucose ever remains in here, then we've got a problem. And that's a sign of diabetes or extreme stress, because there's transporters for glucose found in this proximal convoluted tubule. And if those transporters are maximized, like they're just full and they're just working extra hard because a person has high blood sugar due to uncontrolled diabetes, well, then you're going to see the extra glucose spill out into the blood, because the proximal convoluted tubule can only handle a normal amount of glucose that we would see in a healthy person. But if you have way too much, sugar in your blood because of not enough insulin production, then you're going to see glucose in the urine. But our body is amazing. Like right after Easter, my kids are mowing down on their Easter baskets and have high blood sugars probably most of the day today. They have functional pancreatic cells that are going to just constantly produce enough insulin to take care of that blood sugar. So we don't have to worry about that. And it's a myth that eating too much sugar causes diabetes. It does not. I'd like to tell my kids that so they don't eat so much sugar, but the reality is the pancreas is an amazing organ and it can keep up with what we do. That's not a good reason to eat a bunch of sugar, but we do know that fat cells, increased fat on the body, does cause insulin resistance, which means the cells no longer respond to insulin, and therefore it can't enter our cells and lower our blood sugar. So people that are obese are at risk for type 2 diabetes, where they just don't respond to insulin. Their cells, don't respond, and insulin cannot enter the cells and do its work. So we do know obesity plays a role. Okay, so filtration then, let's talk about the first step. So we have this little tuft of capillaries that that's a branch off the renal artery. So the renal artery branches several times into different arteries that you'll learn about in advanced A&P. And then the final piece is this arteriole and this tuft of capillaries called the glomerulus. It looks like a little tangle, like a tumbleweed, if you know what those look like. Of capillaries. So this just kind of is a simplified version of what that glomerulus looks like. But we can see the blue stands for like electrolytes and small things that can fit through the tiny holes of the glomerulus, and it enters into Bowman's capsule. So this is plasma, but the plasma, when it squeezes out of the glomerulus, we call it filtrate now. Once it leaves the bloodstream and enters into this first part of the nephron, we call it filtrate. The red blood cells do not leave the glomerulus. Large proteins don't leave the glomerulus, and white blood cells do not leave the glomerulus. And you can identify with that because if you ever see red or pink urine, what do we know? There's red blood cells in that urine, right? If you ever see cloudy urine, that's white blood cells and pus and dead cells that might be in that urine, which is a sign of a urinary tract infection. So we shouldn't see these things in the urine. The urine should be clear and it should be lightly yellow because of the pigment that we find in urine, but it should not have any suspended cells like red blood cells or white blood cells. So anything that's dissolved in plasma from our digestive processes can enter into the Bowman's capsule. So ions, sugar, glucose, the simplest form, is small enough to fit through these holes, and amino acids are very small, portions of proteins that can enter into this filtrate. But again, we don't want to get rid of this stuff. So we're going to reabsorb this right back to the blood later on down the piping network. And there's so much fluid that's entering plasma, that's entering into Bowman's capsule, that's reabsorbed back to the blood, that if we didn't reabsorb it, we would pee away our entire plasma volume in 30 minutes. So all the plasma in your body runs through your kidneys every 30 minutes. So we really take our kidneys for granted. And if you have, dysfunctional kidneys and you have to do dialysis, you really appreciate what your kidneys do, and you'll miss that function because you have to spend a lot of time in the chair if you need dialysis. So what drives This process of filtering plasma and entering Bowman's capsule is pressure, hydrostatic and osmotic pressures, depending on the concentration of solutes in the glomerulus compared to the fluid in Bowman's capsule. So obviously things are going to be more concentrated in the blood, so that's going to promote their leaving of the glomerulus and entering into Bowman's capsule. And the interesting thing about the glomerulus, like I said, it's a tuft of capillaries. It has an afferent arteriole that's much wider, bringing unfiltered blood into the glomerulus. And whatever of that plasma is not squeezed out to be processed returns to the blood through the efferent arteriole. So this is the only capillary system in the entire body, and you should write this down, that has two arterioles. Usually we have an arteriole and a venule draining it back to the venous system, but this sends it right back to the bloodstream through an efferent arteriole. So it has two arterioles leading to this capillary bed. So we have pressure within the glomerulus based on the amount of fluid, but this is hydrostatic pressure. So increased blood pressure is going to squeeze more fluid out, right? Osmotic pressure inside Bowman's capsule is going to cause any kind of substances inside the glomerular filter, or the capsule filtrate is going to higher concentration to lesser concentration is going to pull fluid into the glomerulus. So if I have more proteins and substances in the glomerulus, that's going to draw water in, and that's going to prevent filtration. And then if there's any fluid on the outside, pushing on the outside of this glomerulus, that's going to push things into the glomerulus. But if I compare these, I can see I have 30 plus 15 millimeters of mercury in pressure going into the glomerulus, preventing filtration. So that's 45. And I have 55 millimeters of mercury pushing fluid out of the glomerulus. What's the difference? What's my net pressure? 45 acting in, 55 acting out? 10. So my net filtration pressure is 10 millimeters of mercury, promoting plasma being squeezed out of the glomerulus. And these numbers can change, again, depending on what's inside my blood. So osmotic pressure in the glomerular capsule, that is going to cause, if I have more solute, that's going to prevent fluid from leaving. But again, blood pressure is a big factor, and that's the hydrostatic pressure value of 55. That is really going to influence the pushing of fluid out of the blood into the kidneys. So when someone has critically low blood pressure, we need to think, we're not going to get good flow to the brain, and we're not going to get good flow to the kidneys. And if we prevent flow to the brain and kidneys, this person's going to die on us. So we really have to control low blood pressures in our patients. And anytime someone falls in a critically low pressure, we give them IV fluids and we turn it wide open, and we get that. Sometimes we'll even squeeze the bag to get that fluid into those blood vessels as fast as we can, so we don't lose, we call perfusion, which is blood flow to the kidneys and the brain. Okay, so reabsorption, like I said, this occurs in the proximal convoluted tubule. There's capillaries that wrap around this tubule, and we're going to reabsorb 100% of the glucose, 100% of the amino acids, most of the ions like sodium and potassium, and most of the water, because we want to get that back to the blood because that's where it belongs. But anything extra is going to remain in the tubules and enter the collecting duct to be stored in the bladder and excreted from the body. So this absorption is very selective. It uses active transport proteins along the cells that make up this tubule that are actively transporting the different substances. So when we get to the loop of Henle, we have reabsorption. So if we're looking at the ascending limb versus the descending limb, so here's the descending limb of the loop of Henle. We're zeroing in right here. So the descending limb is only permeable to water. So we will see water leaving the descending limb and entering into the bloodstream. It's absorbed by this blood vessel that's right next to the loop of Henle. So it leaves the bloodstream, leaves the tubule and enters the bloodstream. So that's going to preserve our blood pressure. And then as it goes up the loop of Henle, the ascending limb, this does not allow water to leave. It only allows solutes like sodium. Only sodium can leave the ascending loop of Henle, and that's going to enter the blood on the ascending limb. So water enters the blood on the descending limb, sodium enters the blood on the ascending limb. And we really analyze this process and why it occurs and the benefits to the body in advanced A&P. So for general A&P, we're just going to talk about understanding the parts of the nephron and what their general function is. So again, water and salt. Water is reabsorbed on the descending, salt on the ascending, and that's pretty much all you need to know for right now. So when we talk about this secretion then, secretion is when substances are leaving the blood. So it's the opposite of reabsorption. So we have substances going from the bloodstream into the distal convoluted tubule. So we can see potassium and hydrogen ion leave the blood, urea, which is a byproduct of protein metabolism. So when you digest proteins, you release urea. That is excreted. And then the different metabolites of different drugs enter the distal convoluted tubule, and then they eventually become urine. So once they hit that collecting duct, they're out of there. They're out of the kidneys, they're sent to the ureters, and they're stored in the bladder. So this is secretion. So tubular reabsorption is when we're taking it back to the blood, and secretion is when we're taking it out of the blood to be excreted by the body.
I have a quick question about that when it comes to what's being filtered out of the blood.
Mm-hmm.
So what about in the terms of like blood poisoning? Do diseases also get filtered out of the blood in the kidneys then, or?
Well, it depends. Like bacteria are, small organisms, and we can see bacteria in the blood. It can be filtered out, but we don't have specific transport mechanisms for bacteria. So the only type of bacteria we're going to see entering the urine is whatever squeezed through those tiny holes of the glomerulus. So it's kind of just because filtration, the process of filtration is not a selective process. This is selective. We have to have transporters along the tubules to actively transport these materials. Same thing here. We have along the cells, along the membranes of the cells that make up these tubules, we have active transporters, again, that are selectively putting things into the urine. But we don't have that for bacterial illnesses. So those bacteria just squeeze out and enter into the urine, but they don't ever go back. And there's nothing selective about this squeezing. It's just like, turning on your sprinkler, the old sprinklers that go back and forth, or the ones that are little holes poked in your garden hose. Obviously the higher you turn the nozzle on the water, the more water comes out of your sprinkler, right? It's the same thing with the glomerulus. The higher the pressure, the more stuff we filter. The lower the pressure, the less stuff we filter out, but it's not selective. Does that make sense? Yeah, so you're not going to filter out enough bacteria to actually treat your illness. But it does filter out drugs, right? We know that eventually we're going to urinate away, we're going to metabolize all the drugs we put into our system, and eventually they're going to end up in the urine. Or some drugs are metabolized by the liver, and that's not going to enter the urine directly as much as it would by the kidneys, but it does eventually enter into the urine. For example, ibuprofen is metabolized by the kidneys, and Tylenol is metabolized by the liver. So you don't give ibuprofen to relieve a headache to someone who has kidney disease, and you don't give Tylenol to relieve a headache to someone who has liver disease. So you have to kind of be careful of that when you're, practicing with your patients, relieving their pain. You have to kind of understand the function of those medicines and the organs that metabolize them. All right, so moving on to how urine flows then. This is a really interesting concept because we can all relate to the urge to urinate. So the process of urination is called micturition. When we talk about that reflex that gives us that urge that it's time to stop what we're doing and go to the bathroom and empty our bladders. In the medical field, urination is called voiding, right? A nurse might ask, did you void today? Voiding is the term. But the reflex that controls that is called the Micturition Reflex. And urine flows from the kidneys to the bladder by peristalsis, and it's hydrostatic pressure that keeps things moving through the urine or the tubules. But when you think of this reflex, how this works is your bladder is starting to fill with urine, and as it fills to a certain level, it starts to stretch. And there are stretch receptors on the inside of the bladder wall that causes it to contract. So let's look at this reflex here. So urine is filling. It starts to stretch the bladder wall, and you have this sensory receptor, which is a stretch receptor that's stimulated when those cells are flattened a little bit because the bladder wall is stretching. That sends a signal to the spinal cord, the sacral region of the spinal cord. So the very end of the spinal cord is where these nerves enter. And then there's a reflex that goes right back out that causes the bladder to contract. So this is a motor neuron that comes out and it causes the bladder to contract. That contraction causes you to say, "Ooh, I felt that." And voluntarily, we have another motor neuron that contracts the external urinary sphincter, and we prevent the flow of urine when this motor neuron stimulates contraction, right? Because when that little contraction happens, that you're aware of that, and you voluntarily then contract that external urinary sphincter. So this is under voluntary control. This is a skeletal muscle, okay? So then, at the same time, there is awareness that goes up the spinal cord to the brain, to the cerebrum, your thinking brain, that tells you, "Oh, I have to go to the bathroom." You're aware of that. However, this reflex part here, this sensory receptor, the stretching, sending a signal for contraction, that is a reflex that we are not aware of until after it occurs. Just like when you pull your hand away from something hot, your hand is being pulled away before your brain says, "Oh, that's hot." It's a reflex. So, but the key thing is we can prevent that reflex from resulting in urine flow by contracting the urinary sphincter. So what does this mean for daily living? Well, think of babies. Babies tinkle all day long, just a little bit. And you can see this when you're bathing your young children, your young babies. They, like when they're 6 months old or younger, you put them on the towel and they start to tinkle a little bit. And that's because they do not have any control of this external urinary sphincter yet. So they're producing urine, and it's constantly just kind of dribbling out as that bladder gets full. It just dribbles because of this reflex. But then as children get around a year to 2 years old, they gain conscious control of the external urinary sphincter. Now we see a trend in parenting nowadays to not actively potty train our kids until they're closer to 3, and some are even waiting till 4 years old. That's more of a behavioral decision, not a functional or anatomical decision not to use the potty. That's where parents, if they're aware of their anatomy and physiology, by taking general E&P, can understand that a 2-year-old can definitely be potty trained. And in my experience, having 6 children, all my kids were potty trained slightly before 2, and it made life a lot easier and was a lot less expensive on diapers. And it just behaviorally, I think it's good for kids to learn how to use that potty. And it's a little extra work, and you have to I brought the potty chair in the car with us, because when you're getting ready to go to the grocery store, we sit on the potty, we go, toddlers don't go very much, dump it out underneath the car. And if it's bowel movement, you have little bags along, and just like a dirty diaper, right? But you just dump that bowel movement into a little doggy bag, tie it off, throw it in the garbage as you walk in the store, done.
That's great. I need to use that.
Yes. And it just makes life a lot easier. So anyway.
I have kind of a question on it.
Yeah.
So, how a 1-year-old, they may even be potty trained, yet when they fall asleep, they would wet the bed.
Mm-hmm.
So what is it? Because we have voluntary control over it, but we don't wet the bed when we sleep. And
right.
Kids, when they do have voluntary control over it, why do they not have control over it when they sleep?
Yeah, I'll talk. I'm just going to mention that. That's a really good question because there's two parts of that. There is a big psychological component to bedwetting, and not in everybody, not in all children, obviously, but there is a component to that. Some children have underdeveloped bladders, so their bladders, it's overactive. And this reflex initiates more frequently in kids with smaller bladders, and they tend to wet the bed longer, especially if they're hard sleepers. Because remember, to stop that reflex, we have to contract that external urinary sphincter. And this can happen subconsciously when we're sleeping as we mature, but in children that doesn't quite develop as soon as other children. So some are dry overnight. Like I had a son that was dry overnight at less than a year and a half. He didn't have wet diapers at night. And then I had another child that was wetting her diaper until she was closer to 4 years old. So, but again, there was a psychological factor, because what I found is when I decided that we were not going to wear pull-ups, she was not going to wear pull-ups anymore, and she's going to just go to bed, and if she wets, she wets. It took about 4 days of that, waking up wet and that uncomfortable, and she stopped doing it. So there's the psychological piece to it, and you have to kind of trial and error in a real positive way. You don't want to shame kids, right? But you have to trial and error a little bit in a real positive way to determine what that is. Another thing is when kids and humans, anybody can relate to this as well, is we can initiate this reflex by thinking about going to the bathroom. How many times have you ever had a full bladder and you're waiting in line and you're waiting in line and you really have to go and it's finally your turn and you get into the bathroom, you see the toilet, and now you almost are going to wet your pants because you're looking at the toilet and you're thinking that now I finally get to go. And this is what happens with children. Sometimes parents get frustrated when children, are running across the room peeing their pants, or they're in front of the potty chair and they pee on the floor. That's because they're thinking about urinating and this reflex initiates and they can't control it because it's so full. And that's what will happen eventually to people that we don't take to the bathroom. We can suppress this reflex when it's early in the process as the bladder is filling. These action potentials, are coming less frequently when the bladder is starting to fill. But when that bladder is completely stretched, there's continuous action potentials where you stop and say, okay, that's it. I have to go to the bathroom now, right? Have you ever been involved in a project? Maybe you're typing a paper for school, like, oh, I'll just wait. Oh, I got to go to the bathroom. I'm just going to finish this. And then it comes to a point, okay, I got to stop. I got to go to the bathroom. That's because you can no longer inhibit this reflex that is firing to the spinal cord and back to the bladder to contract the bladder. And again, if we look at what promotes urine flow is the parasympathetic nervous system. Is this the rest and digest system, or is this the fight or flight stress response system? Do you remember?
Oh man, I want to say that would be your fight or flight.
Nope, you had a 50-50 chance. It's the rest and digest. Think of the sympathetic starts with an S, and stress has 3 S's in it. Stress, sympathetic. So the parasympathetic is our rest and digest. So it promotes urine flow when we're in a relaxed state. So this is when you're getting ready for work maybe, and you're rushing around getting the kids ready for school or doing what you got to do for yourself, and you're like, oh, I got to go to the bathroom. Well, as soon as I get this and this done, right before I leave the door to go to work, I'm going to go to the bathroom. Well, you're running around and you're busy and you forget because you're not feeling the reflex. The reflex is not initiating because you're suppressing because you're busy. Then you sit in the car, or if you have little children, you sit in the car, you get on the interstate, everybody's relaxed. Now we're on the interstate. And then someone in the back seat says, I have to go potty, right? Now you get mad. You're like, what? Why didn't you go before we left? Well, because the parasympathetic nervous system was not dominating when you were rushing to get out the door, and you're not aware of that reflex and of those signals because we suppress it. Only when you're in a relaxed state are you more aware of what's going on in the bladder and feeling that micturition reflex. So that's why I always tell my kids we're going to empty our bladder right before we get in the car so everybody's on the same page when it comes to stopping for the bathroom. And ourselves too, right? Go before you leave for work so you don't find halfway in your drive that you really have to go. So this reflex is really important for controlling urination, but also preventing overfilling of the bladder and having it back up into the ureters and increasing pressure within the kidneys. Because if we have a patient who has damage to this reflex, either from anesthesia, like you give somebody an epidural, they're not going to feel the urge to empty their bladder. So we have to give them a catheter to make sure we don't overfill the bladder and damage the kidneys. Or if you just have a patient that has what we call a neurogenic bladder, that this connection is damaged with aging, that can happen as well. Spinal cord injury, that can happen as well. You know, the sacral region of the spinal cord, it's going to damage that. So then we give those people catheters to make sure that we're getting good urine flow and it's not backing up and building up into the bladder or the kidneys.
And you can psychologically open up that urinary sphincter even before it starts stretching?
Yes, yep. Yep, as long as there's any urine in there, yep, you can relax it and just go a little bit, right? We've had to do that maybe for a urine test when the doctor says, well, let's get a urine sample. And you're like, oh, shoot, I just went, right? And then you go in the bathroom and you can produce a tiny amount of urine because you can relax that external urinary sphincter. That's under voluntary control, yep. And we can hold it back as well. But again, young children don't have as good a control of their urinary sphincter. So when their bladder really fills, it just flows and they wet their pants, right? Where adults, we don't wet our pants. We can hold it pretty tight, but we're going to get to that bathroom right away. And we're more aware of our, you know, functions and our sensations that are, you know, coming from the body. So when you get into nursing, if you're going into nursing, you know, 12-hour shifts, and not drinking much water, a lot of people can go an entire 12-hour shift without ever using the bathroom. And that's not a good thing. We really need to be conscious about drinking fluid and getting water when we're working, because if we don't get enough fluid in our system, we talked about in the digestive system, you know, that's a number one cause of constipation. So if people want to keep their bowels moving, they need to drink water. And sometimes we have the elderly who won't drink water because of this weak external urinary sphincter. As we age, this sphincter gets weaker. And in women that have had children, weakening muscles around the urethra can cause urinary incontinence in new mothers. And the number one way to treat that after childbirth is to exercise and get moving. A sedentary lifestyle is a number one cause of urinary incontinence in younger women after childbirth. There is a healing period that occurs, you know, after having a child, but after about 6 months, even less than that, 6 months postpartum after having a child, women are able to get active and start working on that again. But if people just sit around or they go to the bathroom every time they get a little bit of urine in there, they're not really strengthening that urinary sphincter. So we can do, you know, different exercises, Kegel exercise, Kegel exercises, it's spelled Kegel. Excuse me, I gotta get a drink. Those are exercises that they tell women to do to strengthen that external urinary sphincter and prevent incontinence after childbirth. And the way to do Kegel exercises are to test the strength of those muscles around the sphincter, the perineal muscles, is to try to stop urine flow. So if you know someone who struggles with incontinence, you can ask them, you know, try going, you know, pee like you normally do and try to stop the flow mid-pee. And if a person can do that, then they have good external urinary sphincters. If they cannot stop the flow midstream, that means they have work to do. And you can just, you know, tell them to do an online search, look up Kegel exercises, how and when to do them. And it's amazing what a person can accomplish with, you know, just working on the strengthening. And I can't tell you, with me having 6 children, there's lots of conversations that mothers have had, we've had at, you know, moms groups and things like that, talking about urinary incontinence. And I've had many women tell me, yeah, I don't play sports, or no, I can't run anymore because, you know, I tinkle because, you know, what happens when you have kids. And they've got 10-year-olds now. And I, you know, I don't want to lecture obviously in those situations, but I say, yeah, that can be fixed. That can be fixed with, you know, special exercises and activity. So, I mean, there's just, you know, you two in this session right now, but anybody else listening, I hope will spread the word that incontinence is not a symptom of childbirth. It's a temporary symptom, but it's not a long-term symptom. And it's not a reason to no longer be active and have excessive weight gain postpartum. We have to get moving again. And I can tell you it works. I'm a runner and I did the work to get my body back in shape after having children.
I had a coworker who had 4 kids in a pretty quick cycle, like maybe just over a year apart, each one of them.
Wow.
And she, I can't believe I got caught up in this conversation with them, but I was in a group of girls and we were all talking about, you know, their vaginas. And she was telling me that sometimes when she would push to go to the bathroom, she could feel her uterus like trying to slip its way out of there. And we had another resident too whose uterus was actually part of the way out, and we had to do a weird catheter with this inflatable ball. I've never seen a catheter like that before. But it was kind of crazy to think that, you know, the things inside you could just be coming right out because
Yep. And that is, that's called a prolapsed uterus.
Yep.
And when we study the reproductive system next week, you'll learn that the vaginal canal becomes ends in a small opening called the cervix, which becomes the uterus. So if the uterus collapses and separates, it can fall through the vaginal opening to the outside. It doesn't have anything to do with urination because the urinary opening for women is very small and it's out, not in the vagina, it's above the vagina. But yeah, that's a big problem. And that's what prevented me from becoming a veterinarian was when I went on a farm call with a farm vet and he had to replace a prolapsed uterus. So we come out to the barn and here's this cow with this long fleshy organ coming out its backside. And he had to like put it into a soapy bucket and wash it off really well. And then he, you know, and it was just hanging there, still attached. And then he had to pick it up and he had to put his hand into it and go all the way into the back of the cow through the vaginal canal up to his shoulder, putting this uterus back inside because that animal would die if you didn't replace that uterus.
Oh my God.
And I thought, you know, I think I want to work in a cleaner environment so I can go out to dinner after work and not need a full shower and antibacterial soap.
Oh God, that sounds disgusting.
Yeah, well, you know, and veterinarians are a wonderful group of people, so I'm not knocking the profession, but it just wasn't for me to be standing in a barn full of manure, you know, with my arm to the shoulder in the back end of a cow. So kudos to those that enjoy that work because it's important, but it wasn't for me. So anyway, so moving on to our last slide, or almost last slide, is dialysis. So I said, you know, if you have functional kidneys, you really take them for granted because this is like a part-time job. If you have to go to dialysis, it's a 4 to 5 hour commitment, 2 to 3 times a week. So that's a lot of time in the chair. And those people develop really close relationships with their dialysis nurse. So if you're looking for a nursing career that is very specialized, very focused, and doesn't allow a lot of patient lifting, then being a dialysis nurse is a great career to consider. It's very scientific. There's lots of different things you have to monitor on these dialysis machines, but you really get up close and personal with your patient because you spend so much time with them. Or other times you're just sleeping and they could care less about you. It depends. In a hospital dialysis nurse, you know, sometimes is dealing with very sick patients that are not really aware of what's going on. But the outpatient dialysis, those people, you know, develop quite close relationships with their patients. So basically what they do is they take an artery and vein in the arm and they create this special vessel called the fistula. And it is a huge vessel because the pressure of the artery and the stretchiness of the vein creates this big vessel that you can feel right on the inside of the arm. And you can actually feel the blood flowing through it. You can feel the buzz of the blood flowing through it. And when you put your stethoscope on it, you can hear the pressure waves from the valves opening and closing of the heart. You can hear it, and it sounds like, picture an empty garbage dumpster and a rubber mallet, someone hitting a rubber mallet on an empty garbage dumpster. And that's what it sounds like, the heartbeat in these large fistula vessels. So the blood leaves the one end, goes through the dialyzing machine, and then comes back on the other end, back into the blood. So their plasma volume just runs through this whole system, and it has a membrane that's selectively permeable, so the wastes leave, but of course the red and white blood cells stay in. But anything that we want to get rid of by concentration differences will leave the blood and enter into the dialysis fluid and to be gotten rid of, right? But we want to make sure this is warm dialysis fluid, so the patient, it's at room temperature and they're not suffering, from any of those effects from losing that blood through the machine. And people have what's called a dry weight. So they come in and their weight's going to be up because they're going to have excess fluid and solutes in their blood because their kidneys aren't doing the filtering job. Their nephrons are destroyed. Some people produce no urine as a result of that. If you have dysfunctional kidneys, you produce little to no urine, and as a result, everything stays in the blood. So they come in with this weight that we record, and then we have settings that are unique to each patient, and then we try to achieve what we call their dry weight. And sometimes that dry weight, even though it's ideal for the patient, they don't feel well at that dry weight because they feel dehydrated. Some of their electrolytes are a little lower than what they're used to, or might be a little higher than what they're used to, depending on, the dialysis settings. And, they have a kind of a tough time that first day out of dialysis. But depending how sick they are, they might feel better too. So it just depends on the individual. So we have different types of dialysis. We have the machines here, and then we have dialysis that occurs at home using a fluid next to the bed, and it goes into the abdominal area. It's called peritoneal dialysis. And those people, this is good for kids, parents with kids that don't want to be dragging them to a dialysis center all the time. They can do, or in people in the nursing home, they can do it right there in their bed, and they hook up at night and they do their dialysis every night overnight. That's called peritoneal dialysis. But you have to really know what you're doing. You have to have good eyesight. You have to have good manual dexterity with your hands to hook things up properly. So people really need to be with it to be able to do peritoneal dialysis. Like I said, it's good for people with kids because the parents are setting them up, putting the kids to bed, and the kids don't have to leave their home for that dialysis.
I was just is it more, the peritoneal version, is that more expensive too?
Probably not, because you don't have to pay a nurse to do it, and you're not maintaining a facility for it. It goes right in the home. So it's more cost effective if you can do it to set it up at home, the peritoneal dialysis. Yeah.
I was just wondering, at my nursing home, we had several people that had dialysis, 2 or 3 times a week.
Yeah.
I didn't know that there was a at-home version. It would have been pretty easy for us to set up at my dialysis machine, but interesting.
Yeah. Yeah. And then if people don't want to do dialysis at all, then obviously they could do a kidney transplant. If they're otherwise healthy and, their kidneys were destroyed by, something earlier in life, then a kidney transplant is an option. But the problem with kidney transplants is those anti-rejection drugs people have to take every day for the rest of their life. And sometimes, the body will reject the kidneys even with those drugs in place. So there's always a big risk associated with that. But that is one way to avoid dialysis altogether, is just to, do a transplant. And sometimes if you have a close enough family member, it only takes one healthy kidney to do the job. So the healthy kidney will pick up, where the bad kidney left off. And they actually leave the bad kidney in place. They don't remove the bad kidney. They leave them there, and they just add the new kidney. So we had a teacher at school who donated a kidney to her father, and her father was able to live, with that.
So they have 3 kidneys?
Yeah, well, the 2 were non-functional, so they don't work anymore, but they leave them in place.
Huh.
I'm not sure why. I could investigate it, but I never asked. But I do know that they don't remove the bad kidney, unless it's cancerous, of course. But if it's just non-functional, they leave it in place and they hook up the new one. So pretty amazing. So when you think of the kidneys, then you're going to think of filtering the blood, helping with blood pressure, maintaining water balance, right? Because we need our kidneys to take the water we drink and digest and send to the blood, put it back to the blood so we don't drop our blood pressure. I'm going to have our live Zoom recording here. I'll put the link from there. So you have your lab videos, practice lab exam. The lab quiz this week is pretty short. I think there's 14 questions, or let me look. Does it say how many points it's worth? No. If I show it now, it's going to show the answer, so I can't show it to you. But anyway, it's a shortened version.
Okay.
I didn't break it up into pieces. There is no webcam requirement for this one. So if you need to use your lab packet to identify different structures and parts, you're able to do that. We're going to be transitioning away from the webcams for fall. So this summer, we're still going to use the webcams, but for fall, we're going to do a different testing technique. We're going to redesign the class. And you guys are in general A&P, so I want to announce this as well, is in fall, we're going to go to a free textbook. It's called OpenStax General A&P. It costs $30 if you wanted the print version of it, but it's a digital version for free. It'll be linked to our website. So if you are taking advanced A&P this fall, you won't need your textbook or access code. So you could sell it, sooner than later if you wanted to.
Yeah.
Something to be aware of. And our lecture homework, we'll still have online lecture homework, but it won't be through Pearson. So we're trying to make it easier for students, to access our resources, and we're going to use some free materials from now on.
Yeah. Good stuff.
Yeah, so the same thing with the unit quiz. You can use your notes on it. It's a one attempt. There it is. Go for it. And then in the extra resources for learning, I have some just notes from the iPad. There's a worksheet that you can work through. This is not required this week. It's just for practice. And then I just have some nice pictures here to help you with the lab stuff.